it is the individual with the cancer who needs to be treated. And incidentally, the word patient comes from a Latin verb called pati, which means to suffer. I know people might think in Hindi the word pati can stand for husband, so does it mean that husband suffered? No, I didn't mean that. The point I'm trying to make is, can we at least take out the suffering from that patient so that the patient can go back to being a person, an individual like he or she was before he or she was diagnosed as a case? Why can't we accept the fact that there is an individual with that? So even if you have cancer, fine, you're a person living with that cancer. It's not as if you label the person as, oh, cancer, which means that person is going to die. No. Let's treat individuals as individuals, and okay, they may be living with this or the other disorder. So ultimately, when we talk of comprehensive genome profiling, it is the tool to drive the revolution of cancer care, because it's becoming more personalized, as I said, moving towards an individualized treatment plan. So one would be where the drug fits all. Two is you identify patient groups, biomarkers, and drugs. And eventually, one patient, one tumor profile, and you have many options. So advances in cancer biology, because CGP also tells you about the biology of that cancer, and it's driving a future where cancer care truly can become personalized. So from precision to personalized medicine, one patient, one tumor profile, more options. I mean, on a broader scale, it's like rather than all the time trying to say my drug is better than somebody else's drug, let's try and understand from a doctor's perspective. What he wants to know is my patient responds best to which drug or treatment regimen. That is more important. So let's try and help doctors identify that patient substrate which responds best to a particular regimen, rather than all the time say my drug is better than someone else's drug. Because even if you do parallel group designs, let's understand that patients in one group have never been exposed to that other drug which was given to patients in the other group. How do you know that same patient may have responded better to that other drug? And therefore, people talk of N of 1 randomized controlled clinical trials, which are difficult to do in the real world of clinical practice, but essentially that's what doctors do in their practice. They try and identify to which treatment regimen does my patient respond the best, and accordingly they treat. So it's not easy. This is about hotspot approach. So here only sequences, select regions or hotspots of a gene are identified, while in CGP, sequences coding regions of selected genes in their entirety. So just to differentiate between the two, I will come to it in some detail in the subsequent slides. This is, of course, CGP, as we already know, comprehensive. FMI stands for Foundation Medicine Institute. It is basically a Roche company, but in Roche what happens is Roche allows these companies to function independent of Roche. So for example, in the US, there is no Roche, it's just Genentech, although Genentech is a Roche company. Similarly, FMI is a Roche company based in the US, but again, it can work for other companies as well. So this way, what happens is you have what I call competitive collaboration. You don't always have to compete with competitors, you can collaborate. You can help other companies also. They may have a certain drug. You might have the test, the theranostic, which can help doctors identify if this patient has this mutation, I will give that drug. That drug need not be a Roche drug. So basically a comprehensive genomic profiling approach of testing all of the known clinically relevant cancer genes for all classes of alterations. Category 1 is the routine single marker molecular test. It's almost like your control F function, like IHC PCR FISH. And it will continue to play an important role in cancer diagnosis, but it could miss a few mutations. Category 2 is the hotspot, which we saw earlier, and that would identify, so all these are part of NGS, pre-specified mutations occurring in very limited areas of genes of interest, and they can fail to detect all classes of genomic alterations. This is the typical NGS technology, and to be very frank with you all, I'm not certainly a person who has done this, so I'm presenting it, but I wish the person who was supposed to take this lecture, Dr. Arun Kumar, if he had come, he's done a PhD in exactly this. So he would obviously be able to give you details, but I still thought rather than say that no one would present on this topic from OPPI, I thought let me at least come and be brave enough to face this audience and show you all what exactly is this NGS technology, right from the sampling, the genomic DNA, then the shotgun library from which you get fragments from the genomic DNA, you hybridize that, then wash it, pull down, capture DNA, DNA sequencing, and eventually mapping, alignment, and also looking for those copy number variants. And this is, or rather these are the steps. So right from the DNA sample preparation, you have a library, cluster, generation sequencing, reference mapping, variant calling, and a bioinformatics analysis so that you can scientifically curate that particular report. Now, moving on from, say, oncology to another field, cardiovascular disease, actually a similar kind of thing exists even in other therapeutic or disease areas. Only thing is it ready for clinical practice? And clearly in research settings, it is already being done. It's just that can you now translate it into clinical practice? The problem, of course, here is we have so many patients. I don't know whether doctors have this kind of time, but all they really need to do is maybe send the patient sample, either a blood sample or in the case of cancer, it would even be tissue sample. And then you could express these genes and ultimately decide, okay, this person has whichever cardiovascular disorder, but can I now map from a metabolic pathway perspective or even a gene expression profile? And you can have personalized care even in cardiology. So we have all these omics, so genomics, transcriptomics, proteomics, and even metabolomics. But of course, the most important omic is also the economics, because if it's too expensive, then naturally access becomes an issue. But clearly, these are the ways you can pick out these alterations. And here, all that I'm trying to tell you again is the reason why we need to understand that it's important to treat that individual with the disease. And even Sir William Osler has said this. What you are seeing in terms of that gun, it's actually a quote from Dr. Inas Inas, an Indian who now has established this coronary artery disease in Indians in the US, where he says, while genes load the gun, environment pulls the trigger. So what he means is ultimately it's the interaction, the play, the interplay between your genes and the environment that decides who gets the disease and who may not. So that's why it's important to understand these phenotypes before treating everyone as, and that's where I keep saying that our forefathers actually knew this much before all of us. And therefore, this could be the path to personalized medicine. So one is this random selection, or second is omics-guided treatment. And ultimately, you follow them through, and the usual outcomes in terms of efficacy, safety, but one could also look at certain other outcomes in terms of economic outcomes, quality of life, etc. Now, a little bit on pharmacogenomics. We all know about warfarin. This is one example that I'm giving. And where you have these alterations in the gene that codes for certain enzymes that are involved in warfarin metabolism. So one is CYP2C9, and the second is vitamin K epoxide reductase subunit complex 1, or VKORC1. Now, because of these, I would say pharmacogenetic alterations, patients need not necessarily respond to warfarin equally. So there's inter-individual and to some extent intra-individual variability, and therefore, with warfarin, the problem is, even if your INR, for example, if you're using warfarin to prevent stroke in patients who have atrial fibrillation, you know that the INR has to be kept in that range of 2 to 3. But in 2/3 of cases, even if that patient is in that range, in 66% of cases, the person can have a bleed. Why? Because the labs which measure INR, there's a lot of variability. They don't use that WHO reference standard of prothrombin. It can lead to variation. For example, you may ask a lab to give you the INR report. It may come below 2, say 1.8. So naturally, you'll want to increase the dose of warfarin based on that report. And then you realize the patient has had a bleed. Why? Because now when you check the INR at a different lab, which is probably better, it was actually 3 point something. Why? Because that 1.8 was not 1.8, it was some 2.6. So there's that coefficient of variation, which, because from lab to lab there is so much of variation, the clinician is actually it's difficult for the clinician to decide. Similarly, with clopidogrel, you also know CYP2C19, so these cytochrome P450 isoforms. Here again, this can lead to a difference in the way you would respond to clopidogrel, and whether this is now clinically significant, that is something that we need to, because sometimes, clinicians tell us, I don't think this makes much of a difference. I've used clopidogrel over so many years in so many patients. I don't think all this is important. It's only in a research or academic setting. And similarly, with statin-induced myopathy, I mean, people have used atorva and other statins in so many patients. Not everybody gets that myopathy, the rhabdomyolysis and myoglobin precipitating out in the renal tubules. But is there a way of predicting it by doing these tests? But then if the tests only are going to be expensive, then again, doctors would hesitate before using tests and then deciding treatment. But this is my second last slide. So the last slide is, all that I'm saying is, just as you have 4 Ps in marketing, in medicine also you can think of these 4 Ps which are very important. So one is in terms of predictive, then of course preventive or preemptive. Some people also mention personalized or precision or pharmacogenomics. And there's one more P actually, which is not there on the slide, and that is pharmionics, which is the scientific study of drug concordance. Means for how long is the patient taking the drug? Is he compliant or adherent to what the doctor has recommended? Because that also makes a huge difference to the outcome for that patient. So that's all that I wanted to leave you with. Please feel free to ask questions, and I would actually learn from you all rather than the other way around. Thank you so much.
Thank you, Dr. Suvarna. Quick questions, if any one of you want to have. Dr. Sharma, yeah.
Quite common in many patients. So those kind of variations actually, like what kind of Indian data actually shows about variation, like few patients are getting, and some of the patient even 80 mg of atorvastatin is given, actually like they are not getting, but few people are like getting certainly this myopathy actually. So is kind of a data is available in Indian population actually?
Sir, the problem in our country is that even if that data is available, it would be in pockets, in small numbers, so I'm not sure it is generalizable. But clearly there is data to suggest that some individuals experience the myopathy. With some statins, this association is higher, especially if you combine it with, for example, gemfibrozil, because that inhibits the metabolism of the statin. Fenofibrate is considered to be less likely to cause that interaction. So that's why, in fact, that's the reason why doctors believe that it's okay. I've used this drug in so many patients and very few have experienced this myopathy. And that's how here the medicine is more in terms of reactive rather than being proactive. Like, there's a common understanding among doctors that you have, for example, you mentioned 80 mg. Of course, 80 mg of atorvastatin, for example, would be for those patients who have had an acute coronary event and now, post PCI, naturally 80 mg initially, and then you can reduce. But in general, people believe that, when you test these drugs on the Westerners, the Caucasians, you require higher doses. When you come to Indians, you require lower doses. Now, that is more, I think, of a clinical judgment. But if you ask me from a genomic perspective, is there data? So from the Human Genome Project, people have actually seen that the differences in the way people respond to drugs between continents or between countries is only 7 to 8%. But within a country, the variation could be as high as 80%. But unless we have more data to prove that, and especially from India, clinicians will continue believing that Indians always will require, like 10 mg ramipril was used in, say, the HOPE study. Here, doctors will start with 1.25 mg, then go to 2.5, and then, if at all, to 10. Yes, sir.
Yeah, with the permission of the chair, Professor.
Sure, go ahead.
So basically, I am trying to understand the personalized medicine, how organoid can extend that, the way for personalized medicine as a tool for the personalized medicine. This is one of the components.
What is the first word you used?
Organoid.
Organoid. Okay.
Spheroid, organoid, mainly I am thinking about organoid sample, how it would be a useful measure for personalized medicine.
I would not be. First, let me try and understand when you said organoid, you meant.
Organoid with a specific chronic problem, the clinical sample, it is tested with used from the pluripotent stem cell, from the blood sample, pluripotent stem cell, organoid can be developed. This organoid shall be used for several testing of the drug, sensitivity, resistance, and the kinetic component, all this together, it comes into that the drug personalized, whether it works or it doesn't work.
No, it's a good thought, sir, and I think maybe there is already some research going on into whether at a cell or tissue culture perspective, whether you can test in vitro ex vivo and then be able to translate that into human beings, because obviously we can't, as you know, clone human beings only for testing. So maybe at an organoid level, it's a bit more ethical to do so.
Yeah. This is one of the aspects. Another question, again with the chair permission on this, how the pharmacy practice qualified people would be useful in that intermittent with the personalized medicine in between that the clinician and then other clinical service. Pharmacy practice nowadays it's emerging. How their service can be utilized, whether you are using that pharmacy practice qualified people service for this purpose?
So, sir, in the US, as you know, it's not called PharmD, it's called DPharm, and those individuals, they actually go through prescriptions of clinicians, and they have the power to actually tell the clinician that they are, maybe they've made a mistake here because they've not looked at, of course, that is at the level of drug-drug interactions, etc. But what you're suggesting, yes, if a pharmacy graduate gets into, precision medicine, pharmacogenomics, and if it is kind of mandated that we need to do that kind of, investigation and get into not just diagnosis but theranosis, then yes, that will feed back into, means when you do, for example, comprehensive genome profiling at the Foundation Medicine Institute, the FMI report will tell the clinician not only about the mutation, but also based on that mutation, which kind of drug is most likely. It's like, for example, sir, when we have infection, so we isolate certain bacteria from the patient's sample and test to various antibiotics. Now here it's almost like you take the tumor cell, maybe from a biopsy, and then test it to, first you detect the mutation, and then test it to different anti-cancer compounds, and select the one to which that tumor cell is most responsive. So something like that is actually happening here.
Thank you.
Yeah, Dr. Suvarna, just quick question from my side. You talked about economics. How is it becoming affordable, the Roche company, for the precision medicine? For example, we've been knowing that warfarin, statin, Selective. Are these metabolic chips available for the normal individuals to be? And what is the cost? Is this affordable medicine or not?
So, sir, with Roche, as you know, we are not really into cardio or even diabetes. It's mainly into cancer. So there, what I have experienced is that these medical oncologists, when they treat patients who have different kinds of cancers with all these mutations, now there's a big push towards making doctors understand that rather than just decide on a particular drug, please send for these tests. I don't know the exact cost of FMI. I've joined Roche very recently, but we are definitely, Roche is all about access, so which means we try our level best to make a particular test also as affordable as possible, because naturally if the test itself is going to be too expensive, then how will the patient afford when he can't even afford the drug? Because sometimes the drug also is extremely expensive, and therefore we have patient support programs. And similarly with FMI, and as I said, FMI is not only for the Roche product, it could be for any product, but at least you do the test, find out the mutation, decide the drug. It doesn't have to be a Roche product.
Okay, thank you very much. May I request Dr. Ravichandran to give a token of appreciation from NIPED. Please, yeah.
Moving on to the third speaker. Now, I would like to welcome the third speaker of this session, Dr. Debashish Mohanty,